It's just wonderful to see everyone here. I am not much of a public speaker, so I'm going to do my best to quickly turn it over to everyone else. My name's Colin Barton. I think most of you know of me. I was diagnosed in 2016 and became chair of the medical committee and on the board of directors since 2017, and have been doing that ever since. Very excited to let you all know that it's grown to the point where in mid-September, we're going to have a full-time director of research and clinical affairs taking over. So he has incredible credentials, and I'm absolutely certain that the research that we're helping to ignite will accelerate much, much more quickly after that. Nancy came to me several months ago and said, Colin, help me out. And she said, we're going to organise a bunch of medical sessions, and what do you want to do? And I sat down and had to think about it. And I was like, well, there's the present, there's the near future. And can you hear me? Everyone hear me? Sorry about that. So there's the present, and there's the near future, and there's the dream future. And so we've basically got 3 panel sessions. This is the first. This is basically what we have right now and how to make the best of it. We're going to have a session coming up a little later entitled Thinking Out of the Box. And it's treatments that are available now, but they're not called standard of care. And so you can get onto them on trial, or you might even be able to get them prescribed by a leading expert that feels comfortable prescribing something that's not quite within the standard of care. And then tomorrow, we're going to be hearing about some of the new technologies that are coming along that the Research Acceleration Committee in particular has been learning about, but also the Research Review Panel, and just some really exciting things. So we know that TKIs totally busted down the doors several years ago, and they're getting better and better, but we also know that they're not the end solution, and there are some absolutely amazing therapies on their way. Between those 3 sessions, we'll also have a very extensive session this afternoon presented by all the doctors that we've funded with our grants, and they'll be talking about the research that they've been working on. So that'll be great. And then there'll be a presentation from the University of Michigan team about the project that they're working on. And there are some pre-recorded videos with international researchers, just so that we don't all think that research is only in the US. That's far from that. There's an amazing amount of incredible research going on all around the world. We have been accepting grants this year through both LCRF and Longevity. And with the Longevity Awards, we had applications from 7 different countries, and with or 6, and a similar number, 6 or 7 with LCRF. So we're definitely getting applications from all around the world. So with that, we'll get started with this session here, which is titled Current Standards of Care, Benefits of a Multidisciplinary Team. And I'm going to let all the doctors here do their own introductions. We have Dr. Gab Gill virtually, and I'm not quite sure how Keith Singh is going to make that all happen, but Dr. Gab Gill has been in the forefront of our research and treatment pretty much from day one, I think. I'll get him online. We've got Ross Camage and Dr. Ross Camage and all of his team here. So Dr. Jonathan Shroom and Dr. Mackenzie Daly, Dr. Simran Rantawa, and Dr. Dara Eisner. And they all make an incredible team, and I'm going to let them introduce themselves and what they do and how they fit into that whole thing. So I think starting off, we're going to have a presentation from Dr. Gab Gill. So, are we ready for that?
Yeah, I can share my screen.
While we're waiting for Dr. Gab Gill to come online, would each of you like to do a brief introduction about yourselves and what you do? And that'd be great.
I'm not actually sure if I'm supposed to be up here as part of this panel, but I got pulled into it. So,
He's
I'm
the
a medical
ringer.
oncologist at Moffitt Cancer Center in Tampa, Florida, and and so I've been treating lung cancer since about 2013, and I'm proud to have a lot of ALK-positive patients who've obviously done well with all the treatments which you all have pioneered. And so I'm incredibly grateful to be here and also to be able to benefit from all this knowledge. Thank you.
Hello. Yeah. I'm Simran Randawa. I'm a thoracic surgeon. I work at University of Colorado, and it's truly an honor to be here and learn from everyone about the latest and everything that's going on with lung cancer.
Does this one work? Oh, it does. Hello, I'm Ross Camage. I'm a medical oncologist. I'm the one who just spoke for about 40 minutes there.
Hey, everybody. I'm John Treem. I'm a palliative care doctor. Just because most people don't know what that is, I can think of it as quality of life medicine.
Hi, I'm Mackenzie Daly. I'm a radiation oncologist. I work for the University of Colorado School of Medicine.
I'm Dara Eisner. I'm a pathologist and molecular pathologist at the University of Colorado, and I'm the director of our molecular testing lab, where Ross will tell you I get very excited when we find exciting things like ALK, and I call the clinicians and say, guess what we found? So there we go.
And my name is Shirish Gadgil. I hope you can all hear me. I'm currently at Henry Ford in Detroit, and just I joined just towards the end of Ross Camage's talk, and it really made me wish I was there with you and not just attending it virtually. And only just now I realized that I'm speaking after Ross. Nor do I have his smarts, nor that English wonderful accent, but I'll do my best. What my task today is, I was told to sort of discuss where we are today. And so the way I've structured this presentation is what I generally cover when I see a new patient, lung cancer patient, but particularly ALK-positive lung cancer patient. And I hope this is not too basic, because I know the attendees in this crowd are very well versed with the topic. So I start off whenever I meet a new patient, particularly with a diagnosis of stage 4 lung cancer, to sort of discuss what is cancer, and to a large degree, or frankly, cancer is a disease of gene abnormalities. So we have two sets of genes, one from our father, one from our mother in every cell of our body. And we acquire damages to these genes throughout our lifetime through a variety of factors. Majority of the lung cancer patients we treat are current or former smokers. And so smoking is clearly a factor that can damage the genes, particularly in lung cells, but a variety of other factors. I know in ALK patients, majority are never smokers, but there are other factors such as radon, such as environmental pollution that can damage this. Now, the thing about gene damage is it can be variable. One can get exposed to a particular agent for many years and never develop gene damage, and different individuals can develop different types of gene damages. And we don't understand why that variability exists, but if a particular gene damage occurs, then those damaged genes give wrong commands to the cells, and that's what makes the cells function abnormally or transform normal cells into cancer cells. And this is sort of a representation of what happens. They keep on dividing. Normal cells can also divide, but only divide under certain circumstances, because that is regulated by the genes. But cancer cells keep on dividing without any rhyme or reason. Normal cells, after they divide up to a certain number of times, stop dividing because the normal genes regulate that. In the cancer cells, that stop signal never comes. The cancer cells keep on proliferating, form a sort of a tumor mass, but then some of the cancer cells learn to detach from the main mass, get into the blood vessels, and can travel to other parts of the body. And normal cells cannot do that. Cancer cells derive that ability because, again, of the damaged genes. So any cancer is our own tissue that is growing when it is not supposed to, and where a portion of the tissue can learn to detach from where it is located. go to other parts of the body and start growing there. If this process starts in the lung, it's lung cancer. Starts in the kidney, it's kidney cancer. If it starts in the colon, it's colon cancer. Though, even though each of these are cancers, the way each of these cancers grow, the areas that they spread to, and more importantly, the treatments that they respond to are very different from each other. And as you all know, even if among lung cancer patients, there are so many differences based on what gene mutation is driving that cancer. Now, a common question I get asked, because a good proportion of the patients I see at diagnosis have advanced stage disease, is that why I was feeling perfectly fine until very recently, and I only have a little bit of a cough. Why are you telling me that I have stage 4 lung cancer? And there are two issues. There are several probably in each patient, but there are two issues that I believe drive the fact that many lung cancer patients are diagnosed with advanced stage disease. One is that we have 2 lungs. We don't need 2 lungs. There are folks that have run marathons on 1 lung. And so you could have something growing in one portion of one lung and not realize it. And the other issue is that we do not have the pain nerve fibers that we have in the rest of the body where we can perceive pain simply because our lungs move. We breathe constantly, and if we had pain nerve fibers, we would be in pain all the time. And so you can have a mass grow in the lung and not know about it until, unfortunately, it has metastasized. And therefore, only a minority of patients, even today, are diagnosed with what we call early stage disease. Now, lung cancer technically can spread to any part of the body, but there are 6 major sites that lung cancer tends to spread to. Lung itself, the pleura or the lining along the lung, and I apologize that that's not mentioned here. So there's a thin wrap that surrounds each lungs. It works like a lubricant because our lungs move during our respiration. And so lung cancer can spread to the pleura. Something called as the adrenal glands that sit on the top of the kidneys are involved in producing endogenous steroids, the liver, the bones, and the brain. Now, mind you, lung cancer can spread to any part of the body, but these are the 6 major organs. Doesn't mean in every lung cancer patient's cancer, it metastasizes to each of these sites. And why certain cancers spread to the brain and don't, or certain cancers spread to the liver or don't, we still don't know that very well. And so the studies we do to find out what the extent of the cancer is done so as to primarily detect metastases in these organs. And therefore, we tend to do the brain MRI. Generally, a patient has had a CAT scan of the chest to work up symptoms that they have may presented with. And then we do a PET scan that scans generally from the neck to the knees. When we first diagnose lung cancer, there are 2 factors that we like to assess in each patient. One is a general assessment of how the patient is doing, or what we call performance status. And that is graded, 0 being good and 4 not being so good. So the performance status, that is how the patient is doing, continues to remain, even with all the advances, a major prognostic factor. And then the other factor is stage. And I'm sure all of you know stage. This is a very significant simplification of stage of lung cancer. Stage 1 being where cancer is limited to the lung. Stage 2, where it has spread to lymph nodes that are close to the lung or in the lung itself. Stage 3 is when the lung cancer has spread to the lymph nodes in the middle of the chest. We all have lymph nodes in the middle of the chest as well as within the lungs. And then stage 4 that has spread to different parts of the body. And mind you, sometimes I've seen patients have a hard time understanding why is spread to other portions of the lung also considered stage 4 disease. Or here there is a very, I guess, a feeble representation of what is called as pleural effusion or fluid within the pleura. I mentioned that lining around the lung. And spread to that pleura, even if there is no spread anywhere else, is also considered metastases or constitute stage 4 disease. And that's because the lung cancer spread to the opposite lung or other parts of the lung or to the pleura, not because it directly crawled there, but a portion of the cancer detached from the main mass went into the blood vessels and spread to other parts of to those areas. So if it spread to those areas like the pleura or other portions of the lung, it has definitely spread to other parts of the body. And what is important to recognize is that even on a scan like a PET scan or the CAT scans, despite how good they are, we don't manage to see all the sites where the cancer has spread. And so even when it has spread to the pleura, it is indicative of the fact that it has spread somewhere else. It's just that in the other parts of the body, the cancer hasn't grown to the extent enough for us to be able to detect it on the scans. And therefore, the treatment is tailored to what the stage it is, because the higher the stage, greater is the probability and certainty with stage 4 that it has spread somewhere else. And therefore, in stage 1 and to a large degree in stage 2, where the cancer may have spread somewhere else, but the likelihood is less, surgery or local treatment plays a dominant role. But when you get to stage 3 and stage 4, systemic therapy, because you're not only dealing with the disease or managing the disease that you can see on the scans, but also the disease that is in other parts of the body, but not big enough to be seen. Now, and once you have determined the stage and once you have determined the performance status, then you decide the treatment. Now, this is an extremely old slide, but I kept it here partly because the concept is still the same. And in some way, it highlights the advances that we have made. So to a large degree in stage 1 and stage 2, upfront surgery to a large degree is the standard of care, though there is now preoperative chemotherapy that is being used in certain patients where surgery is done. And then in stage 3 lung cancer, we primarily use chemotherapy and radiation. And in stage 4, in the past, we primarily used chemotherapy or what we call targeted therapy, though there is now much more use of the immune therapy, which essentially is checkpoint inhibitors. Dr. Creelan, who is on the panel, will be the first one to say we shouldn't be saying just immunotherapy, but we should be specifically saying immune checkpoint inhibitors, because immunotherapy, there are many types of immunotherapy, and though immune checkpoint inhibitors themselves may not have such significant activity in ALK-positive disease, other immunotherapy may in the future play a significant role. So instead of focusing on the specific treatments, what I want to sort of emphasize is as the stage increases, the role of systemic therapy increases, and surgery and radiation play a greater role in early stages of lung cancer. So that brings us to ALK, and this is something that all of you know. This is the first paper that identified ALK translocation as a driver genetic alteration in lung cancer. To me, a historical significance of this is that prior to this, there was only one other cancer, prostate cancer, where a translocation was identified as a genetic alteration. Prior to all this, only translocations were identified as genetic alterations only in blood cancers. What does genetic translocation mean? There's a portion of a gene that goes and sits next to a portion of another gene. That is very simply put. It's a little more technical than that. What is interesting to note is that when you look at ALK translocations, in every ALK translocated patient in the cancer, the extent of the ALK gene that is involved in that new fused gene, for example, fused gene of EML4 ALK, the extent of the ALK gene is exactly the same. But the partner gene extent can vary. So the major partner is EML4, but you have other genes also that can be the partner. EML4 is the partner in almost 85% of ALK-positive lung cancers. But the extent of EML4 may vary. And based on the extent of the EML4, there are different variants, and I'll come to that issue a bit later on. The most important aspect of the deciding therapy is to define the molecular alteration. In the past, we used to use FISH or immunohistochemistry, but now we use NGS because we think it's a better test to detect ALK translocations, but also because when we are testing for molecular alterations in lung cancer patients' cancers, we are not just looking for ALK or EGFR, we are looking for multiple genes. And this test simultaneously can assess multiple genes so that we can identify the primary driver genetic alteration in a patient's cancer. Now, we have been doing this mainly on tissue, but we can now do this in the blood as well. Because cancers shed their DNA in the blood, and then from the blood, we can retrieve the cancer's DNA and do this analysis. A couple of things to note is that detecting translocations is a little more challenging in the blood, though technology is improving continuously. But even today, about only 70% of the patients who have ALK translocated lung cancer can we detect that ALK translocation in the blood. And so the blood-based detection methods are helpful because they turnaround time with the blood test is much shorter. And so we can identify the driver genetic alteration more quickly. But it is critical to note that if the blood test is negative, you still have to do the tissue testing. And it is only after tissue testing can we say whether the patient has a targetable driver genetic alteration or not. And then before we start treatment, we discuss each of our new patients in a tumor board. And I cannot tell you how critical this has become in defining treatment, even in stage 4 lung cancer. Dr. Kamich mentioned in his presentation the issue of oligoprogression and brain metastases treatment and SRS. I can tell you that none of these decisions are made sort of independently. We do this as a team. And I think that 5th point that Dr. Kamich mentioned is extremely critical, that we have to do this together. And that is the greatest sort of asset we have at these academic institutions, because we are partnering with physicians in different specialties that also have focused, that have made their lung cancer as their focus. And another tumor board that has now emerged in many institutions is molecular tumor board. To a large degree, an ALK translocation is very easy to sort of, once reported, act on, but sometimes there can be complicated reports that can be received by medical oncologists like me. And then having partners like Dr. Eisner to decipher the meaning of those alterations is extremely critical. Sorry, go ahead.
We also wanted to spend some time with the doctors that are here.
Sure. Sorry, go ahead. I apologize.
Yeah, much more to go.
No. Actually, we can stop right now and then we can go ahead with the panel.
Okay, terrific. Thanks. So, Dr. Kamich, would you like to talk for a while about when you've got a patient and it's not just as simple as here's your prescription, off you go, everything's great, but which I'm sure you wish it was like that all the time, but it's obviously not. Would you like to talk about how you bring in the whole team, both at diagnosis and ongoing treatment, all those sorts of things?
So sometimes people are going to need multiple inputs from the get-go, and sometimes they're just going to start with one specialty, and then we're bringing people as needed. And so, Keith, do I lift this like further down? Like down here? Like by my belly, closer to my mouth? Okay. This is exciting. I've never had such an interactive thing with the AV people before. I feel we're really bonding. So, I mean, if somebody walks through the door and we already know from the staging investigation that there are CT scans, PET scans, MRI, that they already have stage 4 disease, they're going to land with the medical oncologists. And then we'll bring in Dr. Treem from palliative care. We'll bring in Dr. Daly from radiation oncology as needed. Dr. Eisner from molecular pathology is going to be really important up front to get the diagnosis right. But I think for people who have earlier stage disease, when it hasn't spread or it's only spread to the regional lymph nodes, you really have to gather everyone around the table because Dr. Randau is going to be there. Is it going to be a surgical option or is it going to be radiation? Is it a combination? So there isn't one size fits all. I realize that's a tried and tested statement, but I mean, that's how you do it.
Terrific. And so let's imagine I've just gotten diagnosed and at the time I had a metastasis in my lower spine. It was causing me 24/7, 10 out of 10 pain. I was having difficulty breathing. I couldn't talk normally because my recurrent laryngeal nerve was being impinged. Where do you refer to? How do you go about doing all that process? How do you contact your teammates? How do you get around the table? How's that all work?
Well, so it varies. Dr. Gadgil kind of threw it out that in an academic center, we're all physically relatively close to each other and we all know each other. I think it's much harder for the community oncologists who might not have their favorite radiation oncologist. They may be in a different building or, a different location, same with the surgeons. And so the communication may be harder. In your case, you would probably seen, me or one of my colleagues initially in medical oncology, and then we might reach out to Dr. Daly and we might talk, depending on whether we had the molecular information in hand, maybe we'd start you on a pill because that might work quicker than I can get you in to see Dr. Daly. Or maybe if I don't have that information, Dr. Daly is going to jump in. I don't know. Mac, do you want to talk about, when do you zap a bone met and when do you sit tight?
I think it's just what you said, which is essentially if a patient doesn't have their molecular tests back, that's more the time where I would treat a bone metastasis. But if a patient does have their molecular testing back, then I think we typically would wait to see if the drug is going to take care of the problem. Of course, some patients are in so much pain. We typically can get people in quickly and give them a relatively short course of radiation to get that pain taken care of. But I think most of the time, if the testing's back, we prefer the drug therapy first.
Colin, two things. So one is, can you call us by our first name, if we can call you by your first name?
Absolutely.
Okay. So Dara, can I ask you, how long did it take to get the molecular testing back now?
I would say that
I'm just going to take over for you. Is that okay?
Absolutely.
I would say that in general, you can think of molecular testing as taking about a week and a half to 2 weeks. There are ways that you can make it happen faster. And usually we reserve those ultra fast methods for people who are really symptomatic, where getting an ultra fast result will make the difference between initiating first-line chemotherapy versus initiating a first-line targeted therapy. The problem with trying to do those really fast results is that we compromise the ability to do a larger test like Dr. Gadgil was referring to, a larger next generation sequencing test. It's pretty hard to make that particular type of test come out faster. So if we want to really push for a fast answer, we're asking very targeted questions. Is there an ALK? Is there an EGFR? We're doing those one at a time. And when a patient has limited tissue, if we do those one at a time things, we're using up that tissue that could otherwise be used for a big test. So it's always this push-pull between, do I want to get this really fast or do I want to get more answers, knowing it'll take a little bit longer? And we will absolutely do this really fast if someone is highly symptomatic and it's, okay, if I can find out in the next 3 days whether there's an ALK, an EGFR, or a ROS1, we will get those pushed through real fast. But we always risk that doing that will reduce the probability of getting a bigger, more comprehensive test done.
One of the most common questions that comes up in the support group regarding biopsies is both, obviously we don't really see the ones for initial diagnosis because by the time they join our group, they've already been diagnosed. But certainly with ongoing treatment and progression, do I get a liquid biopsy or do I get a tissue biopsy or do I do both?
I would argue that both is the way to do it. And, the issue with a cell-free DNA test, like we call liquid biopsy, is if someone has been on therapy and you're trying to understand, okay, well, what is causing a cancer to grow despite therapy now? Cell-free DNA testing, liquid biopsy, tests whatever is in the blood, and you don't know which site that's coming from. And so whether that definitely means that what you find in that liquid biopsy is associated with the one site you're interested in or the two sites you're interested in is really basically impossible to suss out. The flip side of that is that a tissue biopsy obviously is invasive. It takes time to process. It takes time to run through the testing. That tissue biopsy, though, if you get enough cells to do the test, can tell you, well, in this patient, the liver lesion is what was growing, and this is what we found in that lesion compared to what was in the blood. And it tells you more granular information about what you're trying to target at that moment in time versus kind of the evolution that's happening for the cancer overall. And so, although payers wouldn't agree with me, I would say that both is the way to go.
Terrific. In regards to surgery, could you tell us a little bit about what types of surgery you do and outcomes, and whether one of the common questions we get asked is, do I need to stop taking my ALK TKI prior to surgery? And we hear different responses. Some doctors are saying come off it 7 days beforehand. Some people say, except for when you can't have any liquids, go ahead and take it whenever. So be interested in all the communal response on that one.
Yeah, I'll take that. So it really depends on what kind of medication they're on prior to the surgery and how much it would affect wound healing and the inner surgical scar healing as well. So sometimes, especially with all the new medications that come out, I actually ask Ross here, hey, is this going to impact wound healing? And if not, then we, continue on with that medication up until the day of and resume right after. But many chemotherapy agents work by kind of inhibiting your immune response, and that in turn impacts our wound healing. And if that's the case, then we like to stop that at least 4 weeks prior to the operation.
I know certainly with
what about alectinib or the TKIs?
Simran and I had this discussion.
Yeah, very
only the other day.
recently.
And I think there's this increasing dialogue between the surgeon and the medical oncologist to sort of say, look, this isn't going to impact wound healing. Take it up to the moment of your surgery, and you can't take anything early. I don't know, Ben, what do you do?
Well, of course, there's VEGF inhibition with some of the TKIs, right? And that may actually impact the wound healing. So from my mind, if it's a small little incision, right, like a mediastinoscopy or something, I'd say, sure, keep going. If you're doing an open thoracotomy or something like that, where there's going to be a lot of real estate, I would say probably holding it maybe 4 or 5 days before the surgery is probably prudent, right?
Even for an ALK inhibitor?
Again, presumably if you're getting surgery with an ALK inhibitor, it's because your disease burden is low enough that getting the disease flare won't be a tremendous downside, right? But again, when do you resume it afterwards, post-operatively? That's another question too.
Yeah, I mean, we actually have the same conversation with radiation oncology, where the radiation oncologist, again, it depends on whether you have a kind of defensive mindset. Maybe something will go wrong, and I have to say we've certainly pushed the envelope in radiation where we kept it going, and I think we're doing the same in oncology. But you're right, maybe we'll push it too far at some point.
Yeah, but I like the idea of being aggressive about it. Yeah.
So I've managed to, so far, obviously had work done by pathologists. I've had radiation. I've had surgery. I haven't had palliative care, and I don't know anything about palliative care other than a little bit of
when do we need palliative care?
Yeah.
Lovely cue. So you're not the only person. Most people that I interact with are also like, what am I doing here? Who are you? Which is fine. So to clarify for everybody, I think if you Google palliative care, you usually get information about end of life care, but I'm here to sort of dispel that as a myth. Probably best to think about palliative care as quality of life care, but the recognition here is that we have an incredible amount of resources that are very disease directed, very disease focused. But living with something like an ALK-positive lung cancer involves more than just medical visits. It involves your family. It involves symptoms, how you feel physically, your emotional life, your spiritual life, all the things that are part of you that aren't disease itself. And palliative care is really a medical specialty that is meant to coalesce all the resources of medical system to help people live with their disease, focusing on things that aren't disease specific to elevate their quality of life, how we can make tomorrow better than today. To borrow Ross's frame from his talk, how can we help people thrive, not just live? And that's really sort of what we try to do with our ALK-positive lung cancer patients.
So can I ask John a question here? So first of all, I would go and see Dr. Treem just because I like hearing his voice. It's very soothing. But one of the things in that slide that I said, things sitting with the patient community in microprint, it said survivor skills. And so how much do you help more than just, medical symptom management, but that whole, how do you adjust your life? Bill mentioned this, this kind of bombshell goes off. How do you figure out who do you tell? What do you tell? What are your finances? What do you tell the boss? Does that fall under you or social work? Or are you part of the same team?
No, I mean, I think that palliative care sits in the middle of a lot of different sort of specialty resources, including social work, including spiritual care, including psychology, including medical care, symptom management. So the idea here is when we sit down with a patient, we really try to do life story work. Like, who are you? What do you struggle with? What's unique about you? And then sort of either we can address those resources within the context of our clinic, or we can connect them to kind of the resources that exist either in the community or within our own center. And so it's very specific to the individual sitting in front of us rather than a kind of an all-comers thing. We sort of say, okay, our new visits, like are 2 hours. We spend a lot of time sitting down and saying, okay, we really want to dig in. What are you going through?
You are probably the least economically efficient specialty.
Ross, you took it from my mouth. I was going to say something.
I would say that our payers.
I would say the hospital must hate you.
Yeah, no one loves paying for the time, but it's important. Feel strong.
Terrific. And when do you refer for radiation? Is it, in my case, it was to try to knock down some pain the first time I had it, and then the second time it was when I had an increase in SUV, but not actually showing up as an increase in size. So technically it wasn't progression, but realistically it was. So anyway, how does that all work?
So I think, some of you may or may not know, but I actually started off as a radiation oncologist. And then I realized I wasn't smart enough to do it. So I had to become a medical oncologist. But I think one of the questions I had when I was a radiation oncologist is, why did they just use palliative doses? Why was there kind of like, you have stage 4 disease and then, you turn the machine down to the lowest setting. So I think over the last few years, maybe because of that background, I've worked really closely with the radiation oncologist and really kind of pushed the envelope. So Mac, do you feel uncomfortable when people start to talk about ablative doses in stage 4? Are you comfortable with them?
Oh, I think we have mounting data to help us feel really comfortable with that. Particularly as molecular targets become more available and we have more long-term survivors, and then that local control or regional control becomes more important. And so I do think there's a bit of an art to deciding dose and how ablative to be and how aggressive to be. And I think that is a weighing of a risk and benefit, and comes the skill of doing that comes with doing it with time. But I guess to answer the question Colin was asking, which was, when does radiation oncology come into play? Times, perhaps when patients had an excellent response, but one area of residual, we would become very aggressive with that area of residual. Or if a patient is on a drug and then only has your term oligoprogression, or a few sites popping up, maybe up to 3 at a time, then we would aggressively go after those sites to kill those cell lines.
It seems one of the most problematic sites for metastases is bone. And how does radiation for metastases in bone tend to work out?
Well, I think we do very well in bone, and it's a site where we generally have a low risk ratio. We're not typically against another organ that's very sensitive to radiation, so it's an area I think where we can help a lot, and also work with our palliative care physicians to improve pain. So about 7 out of 10 patients will have an excellent response to radiation for pain control as well. And then we have some other physicians we work with, like interventional radiologists, who help us do additional ablations and things. So
there are some open mics. I'm not quite sure how that works. Okay. Terrific. So if there's anyone that would like to ask question, yeah, and just everyone try to be brief so that everyone gets a turn. That would be great. Thank you.
Hi, everybody. Stephanie Peace. You're actually my oncologist, Dr. Cleenan, for Moffitt, but I actually have a team that's further south too, but it's nice to see your face here because I knew you'd be here. The question actually is, you were talking about the tissue that you get from anywhere in the body. So when you get the tissue from the brain, where are we working at as far as finding the progression or the mutation that could possibly be happening within that tissue? Is that something that's coming on? Is that something we just kind of, because I know for experience, I've had 3 brain surgeries and I know part of my tissue is out there, and what's coming back is that it's not met. It just stays ALK. So as lorlatinib is continuing to work what it does, as long as it can, is there anything with that tissue looking at in detail to see if there's a separate mutation or something like that? That's my question.
Yeah, well, I think the presentation earlier, Ross really showed that there's that big gray area, the elephant in the room, right? That whole half of the pie chart that we don't know what the resistance mechanism is. And it's probably bypass tracks in large extent. And it's this genomic instability in these cancers, which just like with a lot of other diseases like HIV, where you get resistance as these cells are incubating in the drug over time. One thing actually I think that builds on is this idea of maybe doing cell-free DNA on lumbar punctures, right? I'm curious. So can you, what do you guys think about that?
There's a commercial company that already does that, but in the slide I showed you with the picture of, this is spinal tap. I kind of highlighted a study that we have to do kind of more detailed sequencing. I think Dara might be able to talk about whether cerebrospinal fluid is a good material to go looking in or bad.
So CSF, when we get it, typically doesn't have a lot of cells in it. So even for somebody who has CSF positive disease, the volume of CSF you get relative to the amount of cells is really disproportionate. We did a case just this last week where 32 cc's, a really astronomically high amount of CSF, was taken from someone, and I was able to identify about 6 tumor cells in it. And that's pretty classic for what we would expect with CSF. And so really the liquid biopsy approach, the cell-free DNA testing approach, is what we're starting to think about for CSF. The idea that if the tumor cells have been in that milieu, that taking them away from the cells, taking the fluid away from the cells and looking at the DNA that's floating in there might be more efficacious. I think one of the things to recognize is that increasingly we're thinking about resistance as being CNS-driven resistance versus non-CNS resistance. And that's really just a function of whether the drug that someone is on is a CNS penetrant drug. So if a drug that someone is on is a non-CNS penetrant drug, we might expect that the resistance that's happening in the CNS is going to be different than the resistance that's happening elsewhere in the body. And you can kind of think of it like Darwinian evolution on a 1 cell at a time basis. You've got a drug that's trying to go after individual cells, and those individual cells don't want to be attacked by that drug. So they're going to come up with ways to bypass that drug. And if in the CNS that drug doesn't achieve a really high concentration, those cells don't need to achieve the same kind of bypass to get around the drug. It's going to be a different mechanism compared to what's going to be in the body. It may still be a bypass mechanism, but we increasingly, I think, have to think about resistance as being CNS-driven resistance versus non-CNS-driven resistance.
Thank you. That's great. We've got another question from the audience here, so please go ahead, Amanda.
Hi. Hello. We have a question for someone online. They are asking, Dr. Kamich mentioned during his presentation that there are trials in India and China adding chemo with the TKI. Are there any preliminary results, and do you feel that we will move in this direction?
It was India and Japan, but So they were small studies, and they did seem to show that the response, so that they were done with an EGFR inhibitor plus or minus a course of chemotherapy. And they increased the response rate, they increased the time it took for the cancer to grow. And within relatively modest sized studies, they seem to increase the overall survival. And I think Vincent Lam, who I think is he here in person? He's coming tomorrow. So Vincent is super keen on exploring that in ALK. So one of the reasons he wants to come here is he wants to know whether if he describes it to you, you think that's going to be palatable, or are people like, no, chemo is what you have, when you can't have anything else, or the idea of front loading it to depopulate your cancer. That's what Vincent and to some extent Shirish have been working on behind the scenes for a few months. And they are trying to replicate those Indian and Japanese studies in EGFR in the West. But ALK, so far, it's down to Vincent and Shirish to come up with a plan.
Terrific. I think we've got time for one or two more questions.
I'm scared of the mic. Okay. Dr. Camden, you mentioned earlier the phrases immunocompetent and immunodeficient. And it just sparked something between me and my sister, because I recently have been almost diagnosed with autoimmune disorders after being treated with TKIs. I have every system of my body is going on and offline. That's my language. And so I'm wondering, what is these phrases that you said? What does that really mean? Do I fall in the immunodeficient category, and what do I do about that?
We're going to be careful not to stick too many labels on you, but okay. So I was referring actually to mice, and I don't think you're a mouse. But they were experimental models to show
You
that
went to medical school for that.
You're going to dispute whether she's a mouse, right? About this idea we mentioned before, that the usual immunotherapy in terms of the checkpoint inhibitors doesn't really work in ALK, but the immune system might still be important. I think Ben knows a lot about this, but we had some experimental models that if you put it in a mouse with a good immune system, you can suppress, alectinib works really well. And if you put in a mouse with an immune system that doesn't work, for example, it doesn't have these things called T cells, then the duration of control is less. And so the implication is that it's not just the pill, but the pill somehow, there's some interaction with your immune system. And whether it goes on in all of us, and whether that's the explanation why some people do better than others, that's where at the beginning of that exploration. Whether you have autoimmune conditions, whether that's a good or a bad thing, I honestly don't know yet. So if you're feeling glass half full, you could say, wow, my immune system's doing something. I don't know if it's doing the right thing, but it's too early to say.
One quick thing I would like to add is that your immune system in general could be immunocompetent, but it is possible that the immune system is not able to recognize and attack the cancer. So most lung cancer patients are immunocompetent, but that does not necessarily mean that the immune system can recognize and kill the cancer. So in the mice, what they're doing is they are just completely depleting the immune system. And that tells us that immune system plays a role, but that doesn't mean that would only happen if the patient was immunocompromised. Even if they are immunocompetent, their immune system may not be active against the cancer, and that's the problem.
Terrific. We've got time for one more question from the audience, and then.
This is a question that comes up probably every 2 months on our board. So I wanted to see what the panel thinks about this. So the question always comes up is people get different radiological studies on their ongoing treatment and surveillance. And the question is always, there's two of them. One is, should I be getting a PET scan and how often, in addition to my CT and brain scan? And then the other question is, there seems like to be a lot of variation on how often someone should be getting a brain scan, or if they should be getting it at all. And I know it depends on whether you've already had a brain met or not, but just to kind of clarify it for the room, because this continues to come up like I said, every couple months, someone will ask that question.
I suspect there's not a uniform answer. So we have 3 medical oncologists on the panel. So Shirish, do you want to jump in with that one? And then we'll do Ben, and then we'll do me.
Yeah, so I generally prefer to do a CT scan and use a PET scan only if there is a question that needs to be clarified. There's an issue that needs to be clarified on the CT scan. I tend to do CT scans initially at least every 3 months. I have started extending the interval in a longer sort of patients who are going on for 3-4 years. And I tend to do brain scans at least every 6 months in patients who don't have brain metastases. In patients who have brain metastases, I do the brain scan at the same time as I do the CT scan.
Ben?
I basically have traditionally been exactly the same way, but all this talk about how the burden of disease might actually contribute or accelerate your progression, it's always making me rethink whether maybe getting a PET scan or something on a more frequent basis. You know, if I were a patient, would I be interested in that? I'm not sure. There's just no evidence, right? So we normally just do CT scans every 12 to 15 weeks, and we always have that PET CT in our back pocket if there's something to investigate. But I am curious, and I'm curious what others do too.
So you kind of touched on something that we've been working on for a few years. So if oligo progression, so a small number of sites progressing, is something that you would treat differently, i.e. you would bring in the radiation oncologists or occasionally the surgeons, then how do we maximize detection of oligoprogressive disease? And so, sure, one way is to do a PET scan every single time. The challenge is they cost, I don't know, $8,000, $9,000, whereas a CT is like $2,000. So you get a pushback from the insurance. There's a bigger dose of radiation that may or may not be an issue. But again, if we're thinking that some of you guys are going to be around, we're hoping for decades, we might have to start to think about this. It's not just, well, what have I got to lose? You might have something to lose if we're playing the long game here. And so I actually choose the middle ground, which is why I wanted to go last. So yes, I do just like Shirish. I do the CT scans, every 3 months. But then I also check a blood-based marker, so serum tumor markers. And not everybody has them, but if you look at all 4 serum tumor markers, which for us is CEA, CA125, CA199, and CA2729, in ALK, if you look at all of those, about 80% of people will express one. They usually go down on therapy. And then if the CT scans, everything's fine, but the marker is going up, that's my trigger to do a PET scan. And our detection rate for oligo progression, about 50% of our cases of progression are oligo using that strategy.
So
that's my MacGyver duct tape solution.
I'll add a paperclip to the duct tape.
Go for it.
In the world of laboratory medicine, the next thing coming down the pike on this is what we call tumor-informed liquid biopsy, or tumor-informed cfDNA. And the premise here is that if somebody has enough of the original tumor to get a very large test, much larger than what I would do to ask the question about targeted therapy, labs can identify mutations that are very highly specific for that person's tumor that have nothing to do with therapy, but help identify the tumor. They can then use that information in downstream later date cell-free test liquid biopsies, where the sensitivity is much, much higher than what you see with the types of cell-free DNA testing we've been talking about today. And some of the preliminary data, not as much in lung cancer, that preliminary data is very much on the forefront in colon cancer and pancreatic cancer, but it's just a matter of time before we see it in other tumor types, says that you can use that tumor-informed methodology with regular blood draws to predict radiologic recurrence.
Is that the Signatera test that you're referring to?
Signatera is one of several that are on the market. And of course, there are labs that do this at academic centers separately from the commercial
tests. I just actually had mine done about 2 or 3 weeks ago and waiting for them to run that first big test. And then I'll be getting it done probably between every set of scans that I have. I'll sort of get it done in between the scans.